great pleasure and honor for me to be here today as a speaker at this international conference. I am Dr. Jaki Akhtar from Bangladesh, acting as Deputy Chief Medical Officer, Islamic University, Kushtia, Gynae and Obstetrics Department. I sincerely thank the organizers for this opportunity, and I would like to express my heartfelt gratitude to the organizing committee. Today, I will present my research on evaluation of pregnancy outcomes of postdated pregnancy. Postdated pregnancy is an important issue in modern obstetrics because it carries significant maternal and fetal risk. For this study, I have tried to evaluate the obstetric and perinatal outcomes and highlight its clinical importance, especially in our healthcare settings. In low-research countries like Bangladesh, understanding pregnancy outcomes and improving management strategies are especially important for ensuring safe motherhood and better neonatal outcomes. I believe that international scientific collaboration and exchange of knowledge are essential for improving maternal health care worldwide. I hope this presentation will create fruitful discussions and contribute to better understanding and management of postdated pregnancy. Thank you all for your attention. Let us begin. So, first slide, evaluation of my topics of research is evaluation of obstetric outcome of postdated pregnancy. Name of researcher, Mozdaki Akhtar Institution, Dhaka Medical College, Hospital, Gynae and Obstetric Department. First slide, introduction. Definition of postdated pregnancy. If the pregnancy exceeds 40 weeks, it is called as postdated pregnancy. Importance of postdated pregnancy in obstetrics. Increased fetal risk, that is, higher chance of stillbirth, meconium aspiration syndrome, fetal distress due to placental insufficiency, oligohydramnios. Increased maternal risk, that is, increased rate of cesarean section, prolonged labor, postpartum hemorrhage, higher incidence of birth canal injuries, placental insufficiency and aging. And then second slide shows clinical decision-making challenge. Obstetricians must decide induction of labor versus expectant management. Timing is crucial, that is, too early, unnecessary intervention, too late, increased complications. Importance in antenatal surveillance requires non-stress test, biophysical profile, ultrasound for amniotic fluid assessment. Public health significance, especially for Bangladesh, late booking and irregular antenatal care are common. Incorrect dating of pregnancy, limited access to emergency obstetric services in rural areas. Research and policy importance, help develop national guidelines, protocols for induction timing, provides local evidence for better obstetric practice. Next slide that I show the problem statement. Why is this study important in Bangladesh or our setting? Increased maternal and fetal risk, that is, postdated pregnancy more than 40 weeks is associated with higher risk of stillbirth, meconium aspiration syndrome, fetal distress, cesarean delivery, maternal complications like postpartum hemorrhage, etc. Rising incidence in clinical practice, that is, many pregnancies go beyond the expected date due to poor antenatal follow-up, inaccurate dating. In countries like Bangladesh, delayed hospital visits are common. Lack of local data, especially in Bangladesh, we showed most guidelines are based on Western population, socioeconomic, nutritional, and healthcare differences affect outcomes. Health. So next slide, we can show health guide management protocols. Our research can help answer when should we induce labor, expected management versus induction, which is safer. Reducing prenatal mortality, improves counseling of patients, helps doctor explain risks to mother, supports their decision making, supports national health goals, align with efforts to reduce maternal mortality, perinatal mortality. So next slide shows mention gaps in local data that is showed here. Lack of large physical population data. Most studies are single center Dhaka or tertiary hospitals. No national level or multi-center data. No representation of rural Bangladesh where majority of deliveries occur. Small sample size and limited studies often include only 100 to 150 patients. Cannot generalize results, cannot identify rare complications that is still but neonatal death accurately. For rural versus urban comparison, almost all studies are urban hospital based. Outcomes in home deliveries, district hospital, low resource settings. So next we can go show the lack of standard definition and dating accuracy. Many studies rely on LNP plus menstrual period. Not early ultrasound shows this classification of postdated versus term pregnancy reduces validity of results. Limited focus on maternal outcomes. Most studies emphasize fetal distress, mode of delivery, maternal complications like postpartum hemorrhage, infection, psychological impact. This slide, no long-term neonatal follow-up. Current studies report immediate outcome, but wait, no data on neurodevelopment, long-term morbidity. Lack of risk factor analysis. Few studies analyze why postdated pregnancy occurs, socio-economic status, nutrition, and genital care quality, access to healthcare. Limited data on management strategies. Some studies evaluate induction outcomes, no comparison of expected management versus induction. Optimal timing, 40 versus 41 weeks. Absence of national guidelines-based research, no strong local evidence aligned with WHO and NIC protocols. Bangladesh specific guideline development is weak. Data quality and record system limitations. Many hospitals lack digital records, standardized data collection, incomplete data. Now we can show objectives. Objectives of this research work. General objectives, that is, evaluate obstetric outcome in postdated pregnancy. Specific objectives. Assess maternal complications. Postdated pregnancy can lead to several maternal complications, including increased rate of labor, induction, higher incidence of cesarean section, prolonged labor, postpartum hemorrhage, increased maternal anxiety and stress. These complications not only affect the mother's health, but also increase the burden on healthcare system. Assess fetal and neonatal outcomes. Fetal risks are even more concerning. Fetal distress, meconium aspiration syndrome, macrosomia, oligohydramnia, increased risk of stillbirth and perinatal mortality. Identify risk factors. As pregnancy advances, cesarean turn, placental function begins to decline, amniotic fluid decreases, oxygen and nutritional supply to the fetus may be compromised. Management strategies. Effective management includes accurate dating of pregnancy, regular and dental follow-up, fetal surveillance, non-stress test, ultrasound, and amniotic fluid assessment. Now we can see the methodology in next slide. Their study design was prospective observational study. Study place and duration was Dhaka Medical College and Hospital, Gynecology and Obstetric Department. Duration was 1 year, January 2022 to 2023. Sample size was 100 patients. There were some inclusion criteria. Pregnant women with gestational age more than 40 weeks, single-stent pregnancy, cephalic presentation, age group 21 to 40 years. Relevant gestational dating based on sure LMP or early ultrasound, less than 20 weeks. Women willing to give informed consent admitted for expectant management or induction of labor. There were exclusion criteria, gestational age less than 40 weeks, multiple pregnancy, twins, triplets, malpresentation like breast, transverse line, previous cesarean section, high-risk pregnancy conditions, hypertensive disorder, gestational diabetes mellitus, antepartum hemorrhage, that is placenta previa, abruption placenta, known fetal anomalies, congenital malformations, intermittent days before admission, uncertain dates, unknown last menstrual period, no early ultrasound. Data collection method, enrollment of participants, eligible women identified by admission or antenatal clinic, gestational age confirmed by reliable LMP, early ultrasound, informed written consent obtained. Each participant is assigned a unique study ID. Data collection tool was user-free design structure, pro forma, case record form, data recorded by researcher, trained intern, resident doctor. Sources was patient interview, clinical examination, hospital records. Baseline data collection collected at admission, socio-demographic data, age, residence, socio-demographic data, obstetric history, that is gravida, parity, previous pregnancy outcome, antenatal care visits. Clinical assessments were gestational age, vital signs, fundal height, fetal heart rate. Data analysis, I think it is not necessary to show the slide, but if you if you are interested, then I can show. So I want to show next slide the result. I want to show the result. Results, that is there were basis of demographic profile, age distribution, parity, gestational age, maternal outcomes, complications, prolonged labor, postpartum hemorrhage, infection, obstetric outcomes, normal delivery versus C-section, induction rate, fetal neonatal outcomes, birth weight, upper score, NICU admission, perinatal mortality. Then so I will go to results. Next slide. Results in table 1 shows a distribution of the patient, while most of the patients belong to 21 to 30 years age group, 60%, that is 60%. And 31 to 40 years, that is 40%, only 40%. These young age groups are moved. Table 2 showed demographic status of patients, while 42% just completed their secondary level of education, followed by 43% patients. Husband or farmer, 80% patients married in 13 to 70 years age. The following is given in details. There are illiterate was 9%, primary level was 11%, secondary level 42%. That was the move. Farmer was husband occupation. There were farmers 43%, and income income more than 15,000 monthly. That is 64.2%. Age of marriage 80% was 13 to 17 years. Next slide shows we will see the next slide. Table 3. It shows methods applied for induction in the postdated pregnancy. While 42% were in oxytocin G, followed by 38% were in ARM plus oxytocin G. 14% were in misoprostol, and genoprostol were 8%. Next slide will show table 4 shows total number of cases change after induction in the postdated pregnancy. In oxytocin G, 30% were failed cases, followed by in ARM and oxytocin G, it was 25%. In misoprostol, it was 14%, and genoprostol 0%. That showed that misoprostol were 0% failed after induction in the postdated pregnancy. Next slide shows table 5 shows mode of delivery after induction in postdated pregnancy. While majority had spontaneous vaginal delivery, that were 47%, followed by 33% delivered by cesarean section. 10% had delivery with aid of forceps, and 10% delivery with the ventus was 10%. Then the next slide will show, figure 2 shows indication of delivery by cesarean section, where 30% had fetal distress and 5% had unfavorable cervix. Table 6 shows fetal outcome in the positive pregnancy after induction, while 75% were healthy baby and 20% were distressed baby. There were stillbirth only 5%. Table 7 shows maternal complications, while 4% had postpartum hemorrhage, followed by 3% had pelvic tear and 1% had cervical tear. Next slide, fetal complications. There were meconium aspiration syndrome 5%, respiratory distress syndrome 4%, macrosomia 3%, hyperbilirubinemia 1%, neonatal death was 2%. Now I will go to discussion. That is an important slide. Here I want to show the obstetric outcomes of positive pregnancy have been a subject of extensive research and discussion in the field of maternal fetal medicine. While historically there were concern about increased risks of adverse outcomes associated with prolonged gestation, recent studies have shown new light on the topic, presenting a more nuanced understanding of obstetric outcome in positive pregnancies. One of the primary concerns in positive pregnancies is the increased risk of fetal macrosomia, which refers to a larger than average birth weight. However, recent evidence suggests that the association between positive pregnancies and fetal macrosomia may not be as strong as previously thought. Studies have shown that accurate gestational age assessment plays a crucial role in differentiating between true macrosomia and babies who are lost for gestational age due to prolonged gestation. With appropriate monitoring and timely intervention, the risk of complications associated with macrosomia can be minimized. The risk of fetal distress and meconium aspiration syndrome is also often associated with postdated pregnancy. However, advancements in fetal monitoring techniques have improved the detection and management of this complication. Continuous electric fetal monitoring during labor, along with other methods such as fetal skull pH sampling, ultrasound evaluation of amniotic fluid volume, help identify signs of fetal distress and guide timely interventions such as cesarean delivery or instrumental delivery. There were another important aspects of the obstetric outcome in positive pregnancies was the risks of stillbirth. Historically, postdated pregnancies were thought to carry an increased risk of stillbirth. However, recent population-based studies have suggested that the overall risk of stillbirth in postdated pregnancies is relatively low, and that careful monitoring and timely intervention can further reduce the risk. Close surveillance, including fetal movement counting, non-test can help identify signs of fetal compromise and prompt appropriate action can take it. One randomized control trial compared expectant management versus induction labor in postpartum mellitus in our study, 4% had postpartum hemorrhage, followed by 3% had perineal tear that I will show in the previous slide. 1% had cervical tear. The study found no significant difference in adverse perinatal outcome between the two groups, suggesting that expectant management may be a safe option in selected cases. Whereas other population-based study analyzed a large cohort of postpartum pregnancies and found that the risks of adverse outcome, including stillbirth and neonatal morbidity, increased after 42 weeks of gestation. The findings emphasize the importance of careful monitoring and timely intervention in postpartum pregnancy. This population-based study compared induced labor with expectant management in term pregnancy, including post-term pregnancies. The result demonstrated treated with a lower risk of perinatal mortality and supporting the potential benefits of induction post-pregnancy. Another prospective cohort study prediction model for postpartum pregnancy. This finding identifies index and fetal growth restriction. That clinical decision making. That while advances in obstetric care have contributed to improved outcomes in postdated pregnancy, there is still a need for further research to better understand the long-term outcome and potential risks associated with prolonged gestation. These understanding obstetric outcomes in postdated pregnancy have evolved over time, although there are still concern and increased risks associated with prolonged gestation. Advancement in prenatal monitoring, accurate gestational age assessment, and time interventions have helped mitigate some of these risks. Close surveillance, appropriate timing of induction, and individualized care remain essential in optimizing obstetric outcomes in postdated pregnancy. Continued research in this field will further enhance our understanding and management strategies, ultimately improving outcomes for both mother and baby. So this is the end of the discussion. Then the next slide is about conclusion. We have seen the conclusion. Slide 4. Early labor onset is a predictor of positive prenatal outcome. It is crucial to confirm a postdated diagnosis. Maternal anxiety and side effects from postdated therapy may be listened with proper supervision and consistent monitoring. Due to the limitation of the fetal monitoring system and oxytocin titration, cesarean section is routinely used to terminate the majority of postdated pregnancy at numerous facilities throughout the country. The rate of cesarean section might be reduced with introduction of state-of-the-art infusion and fetal monitoring systems such as automated infusion pump, cardiotopography, fetal skull blood freeze studies, etc. If the woman's cervix has developed and the baby is properly positioned in the birth canal, inducing labor poses little risk to either the mother or the baby. Induction of labor is recommended for women with uncomplicated pregnancy, while consideration of lower section differentiation is warranted for those with complications. Correct evaluation of risk factors and identification of full-term pregnancies may help reduce the likelihood of a negative outcome. There are some keywords: medical induction, labor, postdated pregnancy. So thanks everyone. This was my presentation.
Thank you, Doctor, for your wonderful presentation.
Welcome.
Any questions?
I would like to present the results of our literature review on the theme of non-invasive methods for preimplantation blastocyst quality assessments in IVF programs. Infertility burden is a relevant problem. The World Health Organization estimates that 17.5% of the world's adult population suffers from infertility. So it's 1 in 6 people. In Russia, according to 222 data, 203 newly diagnosed cases per 100,000 women aged from 18 to 49. We have these newly cases every year, and we have no decreasing trend. The problem is the pregnancy rate per IVF cycle varies very wildly from 8% to 46%. And the National Registry of ART in Russian Federation shows data that the probability of pregnancy after IVF remains below 50%. And despite decades of IVF, success rates are still suboptimal, so better embryo selection is urgently needed. So I like to talk a little bit about blastocyst growth and blastocyst structure. So you may know that to develop blastocyst zygote have some intermediate stages. It's embryo on day 2, the embryo on day 3, morula, and finally blastocyst stage. And our review is focused primarily on the blastocyst. Here you can see the structure of the blastocyst. It consists of blastocele, trophectoderm, and inner cell mass, and also zonal pellucida. Current gold standard of embryo assessment is the Gardner embryo grading system. It has 3 parameters: expansion rate, expansion degree from 1, which means early blastocyst blastocele is less than half embryo volume, and hatched, to 6, where 6 means fully hatched blastocyst. The second parameter is ICM quality, from good to poor, and good quality means tightly packed ICM with many cells, and poor means very few cells and disorganized. Trophectoderm quality is kind of similar to ICM, from good when T with many cells forming a cohesive epithelium, to poor with very few large cells. It's a gold standard, but besides, it still remains under 50% successful pregnancy rate. So maybe we need some changes in that system. We have a graph here, and it shows that a strong correlation between embryo quality and pregnancy rates. And there's nothing novel here, but it also shows that the main aim of IVF, living birth rate, is still nearly 50%. So some studies compare the predictive value of trophectoderm and inner cell mass. This makes sense in situations where the embryologist is at a crossroads as to which embryo is better to choose. When one of the embryo has a better quality of trophectoderm, for example, and the other one have better quality of inner cell mass. And this study shows that inner cell mass grade had no statistically significant effect, because P equals 0.47. And trophectoderm grade showed that trophectoderm with grade A 2.32 times higher pregnancy rate. It may be due to the key role of the trophoblast in the implantation of the blastocyst. followed by the development of the amnion later in the embryonic process. So also we studied, so there is a Japanese study. It was a cross-sectional study, and they decided to measure blastocyst diameter, embryoblast area, so in inner cell mass area, and estimated trophectoderm cell count. So this graph shows that this morphometric system has no contradictions with Gardner grading system, because we can clearly see that less diameter means less pregnancy rate, and less estimated cell count means less pregnancy rate. The aim of the study is to show that morphometric parameters can be automated, and it reduces subjectivity of Gardner grading system, because when embryologists use that system, they can only use their sight experience, and it's very subjective parameters. So the next morphological parameter is blastocyst hatching. Hatching is a natural process preceding implantation into a uterine cavity, during which the grown blastocyst sheds its membrane. So there are some studies that studied the correlation between blastocyst hatching and pregnancy rates, and this graph shows that hatched blastocyst lead to higher pregnancy rate, but this evidence is controversial, because some studies shows that there are no positive correlation or even lower implantation for hatched blastocysts, maybe possibly due to damage during vitrification, because zona pellucida plays a key role in protecting the blastocyst. And these embryons were vitrificated without zona pellucida. So most of embryos are vitrificated in Russia. It's embryos without vitrification implantation is a very rare case in our country. Most of them are vitrificated. So these studies, in these studies, it shows that fully re-expanded blastocyst leads to a more highly pregnancy rate, and collapsed blastocyst shows significant decrease of this parameter. Also, there was a study that observed that the faster the blastocyst returns to its original shape after vitrification, the higher the pregnancy rate. And we suggest that embryologists should evaluate both degree and speed of re-expansion after vitrification, because they strongly predict live birth. The next morphological feature is cytoplasmic or embryonic strings. It's a kind of a novel structure because it was observed due to the analysis of time-lapse videos. It's a thin filaments that connects inner cell mass and trophectoderm. Their role is not fully stated, but there was evidence that there were retrograde transport from inner cell mass to trophectoderm. Now we don't know exactly what molecules are transported via cytoplasmic strings. And I will return to previous study, and it shows that embryo string is a good sign for pregnancy rate because it's because it's 1.4 times higher pregnancy rates. So a little bit about time-lapse imaging. These techniques make the process of assessing blastocyst morphology more objective because we don't just see the result of embryo development in the end. We can see all the studies, all the stages. And also we can use AI models to analyze these images because it's labor intensive, and AI models can help embryologists to assess embryos. So such models can predict the development of an embryo from morula to blastocyst stage with 66 to 77% accuracy, detecting abnormalities at the earlier stages of development. So we can move to biochemical methods of embryo assessment. The first technique is detecting embryo exosomes. Exosomes are microscopic extracellular vesicles released into the intercellular space by cells of various tissues and organs. And the embryos can be capable of releasing exosomes too. So this image shows the connection of exosomes between uterine and between uterus and blastocyst. To detect exosomes, scientists use miRNAs because they are better markers, they are more stable and rapidly detectable. So the key findings in these studies were that MIR181 3P and MIR 142 3P is a significantly higher levels in implanted versus miscarried embryos. So the next method of biochemical assessment is cell culture fluid tests. Such non-invasive techniques may include detection of proteome and metabolome in the cell culture fluid. So we can have, you can look at this table. it shows what biomarkers we'll find in cell culture media of embryos. And we have this biomarker named PDBCM. PDBCM is a peptide derived from blastocyst culture medium. It's a degradation product of HERC2. It's almost absent in growth arrested blastocyst, and it's presented in high-grade blastocyst. This biomarker is more qualitative than quantitative, and other biomarkers is more qualitative than quantitative. So this table shows that in high-grade embryos, urea cycle, lipid metabolism, and fatty acid metabolism are more active, and glucose metabolism is more active in poor-grade embryos. Also, this table shows that most of biomarkers that are presented here, and they are evaluated. Most of them are involved in trophoblast invasion, migration, and adhesion, which is logical because implantation success depends on these processes. So, why are non-invasive techniques required in our opinion? Because biopsy of embryo is it requires skilled and experienced embryologist. Also, it's invasive technique, so it can possibly lead to embryo damage. And also, not every ART lab can afford to make biopsies to assess their embryos there. But also, non-invasive methods have their limitations too. For example, AI models require large annotated data sets. Most of culture media analysis have no standardization, so it's needed to detect these biomarkers. Liquid chromatography or tandem mass spectrometry is required, and it's quite an expensive method, and it's not available. It can be not available in all ART labs. Time-lapse systems are expensive but increasingly common, and many biomarkers are still in research phase. In conclusion, in current clinical practice, assisted reproductive technology specialists still lack highly effective techniques for preimplantation and embryo selection for IVF. But implementing a comprehensive approach to embryo grading can reduce the cost of the procedure and improve the patient's quality of life by reducing the number of IVF failures. That's all. Thank you for your attention.
Colleagues, distinguished professor and participants. So first of all, I'd like to express my sincere gratitude to the organizing committee for the opportunity to participate in this prestigious international conference, especially in online format, and special thanks to Jovelian to the support and care throughout all stages of the conference preparation. My
Doctor,
topic
can
today.
you please put it in slideshow mode?
Sorry, just a second. Slideshow. Just a second. So it's visible for you now, yeah? Everything is fine.
Yes, everything is fine.
Okay, so today I'm going to talk about the pathophysiology of gestational diabetes mellitus and modern molecular and endocrine mechanism of that. Actually, my name is Ina Korda, and I'm from Ternopil National Medical University, Ministry of Health of Ukraine. First of all, we have to discuss with you definition of gestational diabetes mellitus. So nowadays, it's defined as glucose intolerance of hyperglycemia first recognized during pregnancy. Glucose concentration are typically lower than those observed in manifest diabetes mellitus. It develops primarily due to profound impairment in insulin resistance, and that maternal beta cells fail to compensate for. According to the International Diabetes Federation, every 6 or 7 pregnancies, around 14, 16, and 17% are associated with diabetes. And of this number, 16.6% have gestational diabetes mellitus, while the majority, almost 87%, have gestational diabetes. Unfortunately, in our country, we're not having precise statistical data about spreading these problems, and especially during wartime, we're having shortage of this information. I can share with you information of awareness of gestational diabetes mellitus among women in Ukraine. So here it's you can see comparative analysis of total awareness between pregnant and non-pregnant women in Ukraine. So we can see that that study revealed statistically significant disparity in gestational diabetes awareness between pregnant and non-pregnant. So pregnant women responders demonstrated high level of awareness, mean score was 13.35 and 3.95, reflecting the efficiency of current antenatal counseling. Controversially, non-pregnant women of reproductive age exhibit a critically low level of awareness, and particularly among those aged 18-25 years and individuals with lower educational attainment. And higher education and age between 26 and 35 years, history of gestational diabetes mellitus, and the most important, family history of diabetes were identified as a key predictor of better knowledge. And this finding actually our scores the urgent need to integrate this gestational diabetes education into preconception care strategies rather than limiting information dissemination to the antenatal period. Antenatal period. Okay, so when we're talking about this pathogenetic mechanism of developing gestational diabetes mellitus, we have to consider some molecular pathways of insulin resistance. So during a physiological pregnancy, as I said already, insulin sensitivity naturally decreases to ensure uninterrupted glucose supply to the growing fetus. So it's for every pregnancy. So in case of gestational diabetes mellitus, this adaptation becomes pathological, driven by severe dysregulation of intracellular signaling cascades and chronic low-grade inflammation. So intracellular signaling cascade is this regulation like when we're talking about that. So we have to consider that these insulin receptor substrates and 1 and 2 phosphodienyl 3 kinase and protein kinase B is the pathway is a primary cascade regulating cellular glucose uptake, lipid metabolism, and protein synthesis. So in two mechanisms of disruption of gestational diabetes mellitus is decreased activity of expression of insulin receptor substrates as 1 and 2, in impaired downstream activation of PI3 kinase and protein kinase B. So this is effect in marked reduction in insulin stimulating glucose uptake by peripheral tissues. Also, we have to consider this receptor activating ligand binding to receptor tyrosine kinase and induced phosphorylation. And second messenger generation is PI3 kinase phosphorylates PIP2 to PIP3, which recruits up to the plasma membrane. Dual phosphorylation is fully activated via phosphorylation at 308 by PADK1 and 473 by TRC2. In case of gestational diabetes, this highly coordinates intracellular sequence is disrupted, leading to blunted downstream metabolic action. In phosphatase and tensin homologue acts as a direct lipid phosphonate antagonist to PI3K by dephosphorylating PI3K, thereby preventing overreaction. We're having negative feedback loops like cytokine signaling proteins and alter insulin receptor substrates proteins, degrade or block even upstream signaling components due to dynamically protect the cell from excessive extracellular stimuli. Inflammatory pathways triggering insulin resistance. Gestational diabetes is actually generally characterized by systemic chronic low-grade inflammation, and inflammatory stress activates these CJUN and terminal kinase and unregulated suppression of cytokine signaling. And consequently, this promotes inhibitory serine phosphorylation of insulin receptor substrates 1, effectively uncoupling the insulin receptor from its downstream metabolic targets. So adipokines are tissue-specific bioactive factors secreted by adipose tissues and that inhibit profound and pro- and anti-inflammatory properties. In gestational diabetes mellitus and severe disbalance between protective and deleterious adipokines accelerates metabolic dysfunction, insulin resistance, and of course abnormal adipocyte proliferation. Leptin regulates energy expenditure and hypothalamic safety. In gestational diabetes-associated obesity, leptin resistance triggers its marked hyperproduction. Accordingly, when we're talking about adiponectin, insulin-sensitive zinc and anti-inflammatory hormone, its circulating levels are critically increased in case of gestational diabetes mellitus. Resistance secreted by macrophages within adipose tissue induces insulin resistance and is significantly elevated in gestational diabetes mellitus patients. Accelerated and impaired lipolysis drives the hyperproduction and accumulation of free fatty acids. Serum-resistant leptin and free fatty acids strongly correlates with elevated HOMA insulin receptors and free fatty acids and glycolic hemoglobin values. Elevated leptin unregulates matrix metalloproteinases, driving and 2 and 9 consequently driving extracellular matrix remodeling and contributing to microvascular complications such as microangio, leading to microangiopathy. Actually, it's interesting because like every pregnancy is having some kind of background of hypercoagulation. And if it goes together, especially with gestational diabetes mellitus, it's like compound effect of each other for like microvascular complications. So impact of placental hormones, endocrine factors. Human placental lactogen is a potent driver of maternal metabolic adaptation during pregnancy. So we have to consider with you a dual role of human placental lactogen. So diabetogenic action and protective action. So, and we're talking about diabetogenic protective action. So we have to understand that it stimulates lipolysis, raising circulating free fatty acids to inhibit peripheral glucose intake. For protective action, it acts as a major stimulation of maternal beta cell proliferation and protects against glycotoxicity induced apoptosis via the GIK2 and CTAT5 pathways. Unfortunately, we're not having like precise data about that. So, because clinical data remains controversial, no direct linear correlation has been established between maternal human placental estrogen concentration and gestational diabetes mellitus onset. So we have to way to go on in this field. Yeah. Surgeon third trimester progesterone levels suppress PI3 kinase by downregulating insulin receptor substrates 1 expression. High physiological concentration of estrogen further attenuate insulin sensitivity. GLUT4 disruption, alter steroid hormones levels impaired GL2 transporter translocation, reducing insulin stimulating glucose uptake by 54% compared to normal pregnancy. Human placental growth hormone and cortisol synergize to diminish hepatic glucogen synthesis and promote gluconeogenesis. When we're talking about thyroid regulation of gestational diabetes mellitus, we are seeing serious dysregulation of thyroid glands in case of gestational diabetes mellitus. So it's seen in the most common during the second trimester. And we can see, like we understand with you that a thyroid gland is like the second place of more common endocrine disorder during pregnancy after gestational diabetes. So high early pregnancy human gonadotropin hormone levels increase the free thyroxine and thyroidine, yeah, secretion by 50%. So we're seeing here interesting correlation. Insulin resistance correlates negatively with thyroid 4 hormones. Low thyroid 4 reduces tissue insulin sensitivity and correlates positively with T3 hormone. Elevates is seen in gestational diabetes mellitus. So, we have to understand that these thyroid hormones directly modulate the expression of rate-limiting hepatic gluconeogenesis enzymes, especially like PIP, C-kinase, and glucose 6-phosphatase. We have to to my conclusion for pathophysiological mechanism of case of gestational diabetes mellitus. Blunted insulin receptor substrates, so phosphogenilyl inositol 3-kinase, and protein kinase. Phosphorylation directly impairs peripheral glucose uptake and stay consolidated by inflammatory Jun and terminal kinase and cytokine signaling. So activation. Accelerated lipolysis driven by adipokine imbalance profoundly low adiponectin elevates circulating free fatty acid, causing systemic lipotoxicity. Placental steroid hormones, progesterone and estrogens, act synergistically to disrupt downstream GLUT4 translocation, dropping glucose transport by 54%. And thyroid dysregulation, low T4 and high T3 worsens metabolic homeostasis by accelerating hepatic gluconeogenesis and altering peripheral sensitivity. So if I'm having some time, I'd like to share some practical part of actually examination between pregestational diabetes and gestational diabetes mellitus, which is done in our hospital. Am I having some time, or I can go smoothly to conclusions and future plans of examination? So organizing committee, can you say if I'm having some times yet? So I understand that I'm having some times. So aim of this study was estimated by between comparing pathology related to plasma in women in that category of patients. So we had totally 60 women with diabetes mellitus. As I said, they were equally divided, split on two parts, for gestational and pregestational diabetes mellitus. And mean duration of pregestational diabetes mellitus in women was 14.6 plus minus 6 years. So, and it was diagnostic criteria due to national guidelines. Actually, it's based on worldwide guidelines. So, and hypoglycemic diet, exercises, glucose monitoring recommended in both groups. And we've seen that it was insulin administration with rapid acting insulin and non-active insulin. So, and compared following criteria between two categories of women, placenta of women with gestational and pregestational diabetes. In addition to this, we compared frequency of placenta insufficiency, intrauterine growth restriction, fetal distress, pretermal distress, maternal hypertension, preeclampsia, polyhydramnion. So, and we can see that in case of pregestational diabetes mellitus group, almost 9 out of 10 women suffer from placental insufficiency, and including the incidence of reduction in ureteral placental blood flow in the pregestational diabetes mellitus group was more than 4 times higher than in the case of gestational diabetes mellitus group. So, and frequency of intrauterine growth restriction in pregestational diabetes mellitus group was almost 4 times higher than in case of gestational diabetes, and half of the patients with pregestational diabetes group preterm delivery was observed. So, and of course, as you can see here, that frequency of maternal hypertension, polyhydramnions, in that the same pregestational diabetes group was 2 times higher than in case gestational diabetes group. Obviously, the duration of exposure hyperglycemia in cases of gestational diabetes mellitus is longer compared with gestational diabetes. As it can be seen, frequency of above criteria is higher in women with pregestational diabetes than with gestational diabetes. And in women with pregestational diabetes mellitus were not undergoing insulin administration. This phenomenon would be natural, but they were. On the other hand, administration of insulin cannot provide and maintain a natural level of glucose in blood during a day. Probably that this obtained data will allow the development of new approaches to the screening and treatment of pregestational diabetes mellitus, which is why this issue requires more attention. So, clinical implication and future perspectives. Early detection, identification of novel genetic, epigenetic, and molecular markers to enable risk stratification during the first trimester. Personalized medicine, tailoring preventative and therapeutic protocols based on individual endocrine, metabolic, and environmental profiles. So, target therapeutics, exploring the utility of specific antioxidants, anti-inflammatory agents to attenuate cellular stress and insulin resistance. And intergenerational health, implementing a stringent postpartum follow-up for the maternal offspring's diet to mitigate the long-term risk for type 2 diabetes in future for that category of patients. So thank you for your attention. Thank you one more time, organizing committee, for this great opportunity. And thanks all board for helping us and for during this work. You can see like in which condition we are working here as a practical doctors in when Russia is bombing us, when we're not having lights, but we still have to continue our job for saving lives of our women. And thank one more time, and see you in hopefully pretty soon in welcome to Ukraine. Welcome after, of course, war will be stopped with your help. Welcome to our university, Ternopil National Medical University. Okay, thank you one more time.
Good morning or good evening, everyone, according to your time zone. Today, I will present a systematic review for comparative effectiveness, safety, and cost effectiveness of labor induction method. So, in the first slide, abstract at glance, there is increase in induction rate worldwide, and choosing the most effective and safest method has become increasingly important, both clinically and economically. So this review included 10 randomized controlled trials involving over 8,600 women. Overall, oral misoprostol and Foley's catheter showed similar effectiveness and safety profile. However, combination method constantly shorten induction to delivery interval. Importantly, outpatient Foley catheter pathways appear substantially more cost-effective. So the evidence suggests that the optimum approach may depend more on patient context than on one universal superior method. Introduction. Why labor induction matter? Labor induction is one of the most common performed obstetric interventions worldwide. Induction rate continues to rise globally, now approaching around 29% of births in many high-income settings. Because of this growing prevalence, identify methods that are not only effective and safe, but also economically sustainable has become increasingly important. In terms of the clinical problems, although multiple induction methods are available, including prostaglandin, oxytocin, misoprostol, Foley catheter, and combination approach, uncertainty remains regarding the optimum strategies. The literature shows inconsistent findings regarding vaginal delivery rate, cesarean section rate, and adverse outcomes. In addition, healthcare systems are increasingly under financial pressure, making cost effectiveness an important consideration alongside clinical outcomes. In the methodology, we conducted this systematic review according to the PRISMA 2020 guidelines. We searched for major databases, including PubMed, Scobius, Web of Science, and Embase for randomizing controlled trials published between 2015 and 2025. We included studies evaluating pharmacological, mechanical, or combination induction methods in term pregnancies. Risk of bias was assessed using Cochrane ROB2 tool by 2 independent reviewers. So here, when we come to the study design, a total of 339 studies were initially identified. After duplicate removal and screening, 10 randomized controlled trials met eligibility criteria and were included in the qualitative sentence. The included studies were conducted across multiple countries and include both nulliparous and multiparous women. The interventions evaluated include the oral misoprostol, polycatheter, balloon catheter, and dilepants and combination methods. Several studies were designed as non-inferiority trials, reflecting that growing view the some induction method may be clinically equivalent rather than clearly superior. So this is one of the main findings, misoprostol first polycatheter. The large PROPAT 2 trial demonstrates no statistical difference between oral misoprostol and Polis catheter in either vaginal delivery rate or cesarean section rate. This suggests that both methods provide comparable effectiveness for cervical ripening and labor induction in women with unfavorable cervix. Although there was a numerical difference, statistical significance was not reached. When it comes to effective combination method outperform, across multiple randomized trials, combination method constantly shorten induction to delivery interval and improve vaginal delivery within 24 hours compared with single method approaches. This likely reflects a synergistic effect where mechanical cervical ripening enhances responsiveness to prostaglandins. So when it comes to induction of labor, protocol really matter. So in the next slide, that shows us that this study also showed that protocol design matters. For example, shorter Follis catheter duration appeared more effective than prolonged ripening, while misoprostol dosing frequently itself did not significantly alter outcomes. Importantly, parity and Bishop score appeared more predictive of success than minor protocol variation. When it comes to safety, overall safety outcomes were reassuring across most studies and low rates of serious maternal or neonatal adverse events. However, safety appeared highly context-dependent. For example, in women with PROM, balloon catheter methods showed a trend toward increased infection risk compared with oral misoprostol. Combination approach may actually improve safety by allowing lower doses of misoprostol, potentially reducing tachysystole and related complications. When it comes for cost effectiveness, so in this slide, you can see that the review also highlights the important economic consideration. Although important costs between oral misoprostol and polycatheter were relatively similar, outpatient Follis catheter pathway result in substantial cost saving. Additionally, induction at 41 weeks appeared more cost effective than expectant management, particularly among nulliparous women. risk of bias. So overall, methodological quality was good, with 8 out of 10 study as low risk of bias using Cochrane Rope Tool 2. In the discussion, the key insight, the findings suggest that labor induction should be individualized rather than protocol-driven. Equivalence between oral misoprostol and Foley's catheter gives clinician flexibility to tailor introduction based on patient's characteristic and local resources. Combination therapy appear particularly promising in women with unfavorable cervix. And when it comes for limitation of our systematic review, the review does have limitation. There were significant heterogeneity between studies regarding population, protocols, and economic analysis, which limit formal meta-analysis. In addition, many trials were open label inducing potential performance bias. Finally, patient-centered outcomes such as satisfaction and autonomy were insufficiently reported. Conclusion. Oral misoprostol and Foley's catheter appear similarly effective and safe as first-line induction methods. Combination approaches may provide superior efficacy, particularly in women with unfavorable cervix. In PROM, pharmacological methods may offer a safer profile than mechanical approaches. Finally, outpatient cervical ripening and parity-tolerant induction strategies may improve healthcare efficacy and cost effectiveness. Further research direction. So the optimum method of induction is not singular. It should be individualized according for membrane status, parity, parity and cervical status, and available healthcare resources. Further research must standardize outcome reporting, refine combination protocols, and integrate patient-centered outcome to fully evaluate induction strategy and guide evidence-based policy. Thank you. Thank you. I'm happy for questions.
Would like to thank the Congress authority for the invitation to presentation my work, and especially my thanks to Dr. Jovelyn Wallace. Okay, I am going to speak about papillomavirus in a 6-year-old immunocompetent girl. Of the 14 papillomaviruses of human origin, 4 have been associated with human diseases and are of particular interest. BKB, GSAB, TSV, and Merkel cell papillomavirus, MCV. Reactivation of BKB in immunocompromising individuals, especially with the use of stronger immunosuppressants in recent years, can cause serious pathology in kidney and bone marrow transplant. Please, can you go back with this slide, please? Thank you. In immunocompromising individuals, GSAV can cause symptomatic brain infection, the progressive multifocal leukoencephalopathy, la trichodysplasia spinosa caused by TSV is a rare skin condition that primarily affects the face, and is characterized by the appearance of spine bumps skin. And the MCV, polyomavirus, is detected integrated into the DNA of Merkel cell carcinoma tumors. Okay, the following, please. Yes. About the molecular structure, these viruses are small, non-enveloped, 42 nanometers in diameter, with a capsid that houses a circular double-stranded DNA genome of more than 5,000 nucleotide pairs. The genome is divided into an early region, which is called the T antigens, involved in transformation, viral replication, regulation, and gene expression, and a late region, which encodes the three capsid proteins, BP1, 2, and 3, and a protein called RNA protein, whose function is unknown. The follow, please. The next, thank you. This is a summary of the polyomavirus biology. When the virus infects a cell, this is the drawing as a cell, and we can follow the numbers. 1, virus binds to ganglioside receptors in the surface of the cell. Then 2 is internalization. 3, movement from late endosomes to the endoplasmic reticulum. 4 and 5, the genome is transported to the nucleus. 6 and 7, expression of the early genes, the T family, and replication of virus. 8, expression of late genes. 9, assembly of B proteins to form capsid, in which the newly synthesizing viral DNA is packaged. 10, virions are released primarily from infected cells following cell lysis, and 11, a small fraction of progeny virions can also be released into the intracellular environment through a not-lytic exit pathway dependent of cellular secretion. The next, please. What happened with this infection in children? VKV, polyomavirus infection, is usually asymptomatic in children and is localized to the kidney and lower urinary tract. It's generally assumed that the initial infection occurs in the tonsils, and infected monocytes disseminate the virus to other tissues and organs, particularly to the kidney. Primary infection appears to be asymptomatic, but the virus persists in the epithelial cells of the kidney and lower urinary tract in a state of viral latency with minimal episomal replication. The next, please. The photos show biopsies of normal urothelium at the left, with the granular chromatin nuclei, and at right, we see the urothelium, but now infected by the polyomavirus, with nuclei with uniform chromatin cells of the ground glass type. And the next, we see infection by polyomavirus in kidney. In this case, the renal tubular cells can be indirectly recognized by an urine sediment when epithelial cast containing decoy cells appear. Now I'm going to explain why the name of decoy cells in relation to the name of this cell infecting polyomavirus. The next, please. Here see another example of remains of a cast with decoy cells. In this case, with another stain, Sterheimer-Malvin. Okay, next, please. So we present a clinical case, a 6-year-old girl presented to the hospital with abdominal pain, vomiting, right lower quadrant pain, suspected appendicitis, later ruled out, and painful urination. She was initially diagnosed with gastroenteritis and suspected urinary tract infection. Here, cephalosporin was administered. The urine sample showed trace of protein, some pyocytes, and typical polyomavirus infecting cells. These typical cells show elevated NC ratio, blurred fuzzy chromatin, and accumulation in the nuclear membrane of the heterochromatin. These cells are known as decoy cells. Here we see in a fresh urine polyomavirus infecting cells, decoy cells at the center of the thought. This next, please. Here, see another example of this infection. It's a cell with a big nucleus with high NC ratio, and the chromatin is dispersed, and there are some accumulation of the chromatin in the membrane nuclear. Okay, the next, please. Another characteristic is of the cells is a cytoplasmic extension present in some of the cells, which are were named comet cells. Comet cell here at the center of this smear that is a urine sediment. In the next, we see 3 thoughts. The first cells on the left shows the ground class chromatin nucleus, the characteristic nucleus of this polyomavirus infection. The middle one shows chromatin, but in thick and irregular deposit. And the third, at right, is a comet-shaped cell with a thick amorphous inclusion in its nuclei. This last is taken by phase contrast. The name decoy cells for the cell infected by this virus derives from the decoy ducks used by the hunters to lure real ducks. The resemblance between decoy ducks and real ducks refers to the similarity between polyomavirus infecting cells and neoplastic cells. The difference between a viral and a plastic cells should always be established by the chromatin structure. Please, we come back to the before. Yes, go back, please, one. Here, thank you. I said that the difference always is the structure of the chromatin. Viral cells, not only polyomavirus, but herpesvirus, cytomegalovirus, have always a fuzzy chromatin, homogeneous and very without granular chromatin. While neoplastic cells have granular, irregular, and well-defined chromatin. Here we see the comparison between decoy cells left and cells from high-grade human urothelial carcinoma. I said neoplastic cells. Okay, the next, please. To confirm the diagnosis, the following tests were performed. Immunostaining of the cells with mouse monoclonal antibody for the detection of BP1 polyomavirus capsid protein. And after the incubation was adding a avidin biotin peroxidase complex, and the cells were visualized using a diaminobencidine substrate and hydrogen peroxide. If the cells show brown nuclei, it means that is positive for viral capsid protein. This isn't told immune staining for protein of the capsid of the virus. And the other the other method is for diagnosis. It was the real-time PCR in plasma, detecting the DNA of polyomavirus. Okay, the following, please. Our conclusion is the BKV is one of the 14 papillomaviruses of human origin and is associated with nephropathy and hemorrhagic cystitis. Following natural transmission of the virus during childhood, the virus VK remains in the urinary tract with intermittent reactivation and low levels of viruria. In 5 to 10% of immunocompetent adults. But the reactivation can occur in immunocompromised individuals. In the case presented, the girl's symptoms were ambiguous, and a bacterial urinary tract infection was initially suspected until decoy cells were detected in the urine. Although the morphology of these cells is characteristic, confirmation can be performed by the two methods that I said before. The serologic association of primary infection with upper respiratory tract infection suggests that transmission most likely occurs via the fecal, oral, or respiratory route, but BKV can also be transmitted through semen transfusion in organ transplantation, particularly renal allograft. In children with fever painful urination or increased nasopharyngeal discharge, it is important always perform a urinary sediment examination for decoy cells. Otherwise, primary polyomavirus infection may go undetected. We present here a rare case of transient symptomatic virus infection in a 6-year-old immunocompetent girl. All published studies refer to immunocompetent, immunocompromised adults, but to our knowledge, only 2 cases of primary childhood infection have been described to date, both published by our team. Please, we can return to the before photo, the before, the previous. Thank you. Here. And here I show the 2 papers that were published by our group, where we talk about the primary infection. Okay, follow the next, please follow here. In the first place that we published, we see some cells showing an amorphous deposit of chromatin, as we can see in the showing in the picture. And this decoy cells variant is called type 4. Type 4. The next, please. And here I show a correlation between the fresh and stained cells. These cells are all infected by polyomavirus. Fresh on the top, and then we see the cells stained with ginseng. Okay, the next. And we emphasize the importance of urinary sediment examination in these cases to diagnose polyomavirus infection in children. Okay. And at last, I want to thank you very much for your attention.
Analysis and frequency of intraepithelial lesions, precursor to cervical cancer, identified in the main objectives of this study were The main objectives of this study were to understand the frequency and characteristics of intraepithelial lesions in Bogota, to identify lesion types according to the 2014 Bethesda system, to analyze relationships between lesions, age, microbiota, and sample quality, to interpret the study findings and their clinical implications, and to consolidate recommendations for screening and public health programs. Background. Globally, cervical cancer is the fourth most common cancer in women. In 2022, an estimated 662,300 new cases were diagnosed worldwide. Higher incidence rates occur in low and middle-income countries. In Malaysia, cervical cancer is strongly associated with persistent infection by high-risk human papillomavirus. The most frequent genotypes associated with cancer are type 16 and 18. In Latin America, cervical cancer remains a significant public health problem. Incidence and mortality rates remain higher than the global average. This reflects inequalities in access to screening and prevention. In Colombia, cervical cancer is one of the leading causes of cancer-related death among women between 30 and 59 years of age. Approximately 4,700 new cases are diagnosed annually. This study is supported by multiple international and national references. These include the World Health Organization, the International Agency for Research on Cancer, the World Cancer Research Fund, and the Ministry of Health and Social Protection of Colombia. Screening plays a critical role in early detection. Cytology is recommended for women under 29 years of age. HPV DNA testing is recommended for women over 30. Early detection can reduce mortality by up to 70%. Ideally, both methods should be combined for greater diagnostic sensitivity. This study was conducted in the district network of cytopathology laboratories in Bogota. Aims to determine the actual frequency of precursor lesions in the capital. Provides key information to strengthen prevention and control programs. Samples from the years 2021 and 2022 were analyzed. A total of 1,997 cytology samples were reviewed. Data were obtained from the Public Health Laboratory. All samples were classified according to the 2014 Bethesda system. Grouping by age, microorganisms, and endocervical representativity. Readings reviewed by a pathologist and a cytohistotechnologist. A total of 1,997 cytology samples were analyzed. Approximately 9.46% showed epithelial abnormalities. 90.54% were negative. 1,602 slides contained endocervical cells. 368 showed microorganism identification. Among the abnormal findings, ASCUS was the most frequent alteration. It represented 60.85% of all abnormalities. Low-grade lesions, known as LSAL, represented 31.22%. ASCH lesions accounted for 3.7%. High-grade lesions, known as HSAL, represented 4.23%. SCUS was identified as the main alteration in this study. Between 40 and 50% of ASCUS cases may be associated with high-risk HPV infection. This condition was highly frequent in women between 15 and 30 years of age. ASCUS cases require HPV triage testing and strict clinical follow-up. What does ASCUS mean? A diagnostic category within the 2014 Bethesda system indicating minimal cellular alterations insufficient to classify the lesion as low-grade intraepithelial, but not entirely benign either. ASCUS presents subtle nuclear changes. These include slight nuclear and mild irregularities. The cytoplasm shows minimal or reactive alterations. These changes may be confused with inflammatory, infectious, or reparative processes. ASCUS does not meet the full criteria for LSAL. However, it raises diagnostic suspicion. This category indicates minimal alterations that are not entirely benign. Therefore, adequate follow-up is essential. Between 40 and 50% of women with ASCUS present high-risk HPV infection. Genotypes 16 and 18 are particularly relevant. Higher incidence in sexually active women aged 15 to 30, the most affected group in the study. Recommended management includes HPV DNA testing to distinguish transient lesions from real progression risk. Colposcopy if HPV results are positive. Repeat cytology after 6 to 12 months if HPV results are negative. Associated infections should also be treated. Strict follow-up is essential to prevent progression. In young women, ASCUS may resolve spontaneously, but with high-risk HPV, there is a risk of progression to LSIL or HSIL. Low-grade lesions, known as LSAL, represented 31.22% of abnormalities. These lesions are commonly associated with HPV infection or SIN-I. They are most frequent in women between 15 and 45 years. High-grade lesions, known as HSIL, represented 4.23% of cases. These include SIN-2, SIN-3, and carcinoma in situ. They require priority management. Women between 15 and 30 years showed higher frequencies of ASCUS and LSAL. Between 31 and 45 years, there was an increase in HSIL cases. Between 46 and 60 years, ASCH was more frequent. In women over 60 years, frequency was lower but diagnostic difficulty was greater. Adequate sample representativity was observed between 15 and 46 years. In women over 60 years, representativity was lower due to tissue atrophy. The transformation zone is critical for diagnosis. Lack of endocervical cells increases the risk of false negative results. Several microorganisms were identified in the samples. The most frequent included bacterial vaginosis, Candida species, Trichomonas vaginalis. Other microorganisms included actinomyces species, herpes simplex virus, and lactobacillus species. Microbial imbalance may promote inflammation and persistence of HPV infection. The high frequency of ASCUS indicates significant HPV circulation in the population. Coexisting microorganisms affect cytological interpretation and increase clinical risk. Young women showed greater vulnerability to cervical lesions. Pre-analytical errors reduced diagnostic reliability. Overall, the findings are consistent with international studies. ASCUS is the most frequent alteration identified in Bogota, especially among young women. LSIL and HSIL require close follow-up due to progression risk. Sample quality directly influences screening sensitivity. Sexual education, HPV vaccination, and screening programs must be strengthened. Additional studies are required to better correlate HPV infection with lesion types. The following references support the scientific evidence presented in this study. They include systematic reviews, clinical guidelines, and epidemiological studies related to cervical cancer screening and management.
Of all the wonderful doctors here today with their fantastic presentations, I just want to ask a simple question to everyone. How many of you, and how many times have you reassured a woman that her light periods is normal? And considering the fact that this harmless symptom can be an early sign of female genital TB. Yes, a disease so capable of permanently destroying your fertility. Good evening, everyone. I'm Dr. Nehal Sahai, and I'm Assistant Professor at Netaji Subhash Medical College and Hospital, India. And today, I will present an evidence suggesting that hypomenorrhoea may be an indirect clinical marker for the early detection of female genital TB. Next slide. Minute. Next thing. Next slide. Okay, sorry for the interruption. So, female genital TB is usually a silent disease. Most of the women will present to your OPD only when the infertility has already developed or a much progressive earlier symptom, scanty menstrual blood flow. But unfortunately, as clinicians, when the patient comes with doctor, my periods has become very light. We usually think that it can be attributed to some stress, hormonal imbalance, or weight changes. But we always overlook the diagnosis of, can it be genital tuberculosis? Now, why does it matter? As you can look in the picture, the burden of the disease, TB, one of the mainly infectious diseases which globally causes 10.8 million new cases recorded in 2024, of which the pulmonary part is the major one, and the extrapulmonary part contributes to around 15 to 20%. TB, which is prevalent in Southeast Asia, Africa, and other endemic regions. So, when we look that the major cause of infertility and TB endemic countries is because of this, these patients are usually asymptomatic and are usually frequently diagnosed late. Now, the question comes, can a simple symptom of scanty menstrual blood flow has the capacity to be able to predict a serious disease such as female genital TB? What are we missing? The main part. Most of the studies have gone through the infertility taken as a correlation with female genital TB because the patient usually comes at the later stage with infertility, chronic pelvic pain. But a more diseasing symptom or a more early symptom, the scanty menstrual blood flow, is it missed or it can be taken early to detect an early marker for female genital TB? For this, we have to go through the pathogenesis part. Now, why does TB cause scanty periods? It's very simple. If you look into it, through the hematogenous route, the TB bacilli enters the endometrium. It disrupts all the endometrial glands because of the chronic granulomatous inflammation. Now, when the glands are disrupted, the healing takes by fibrosis, finally leading to adhesion. And sometimes serious adhesions cause Asherman's also. Now, when due to adhesions, the reduced vascularity is there, which means less amount of the endometrium available for to shed in the next cycle, which explains scanty menstrual blood flow, thus hypomenorrhoea. As you can see the histopathology and all the wonderful doctors today here, we have already read and studied in the past how a histopathological slide of a tubercular granuloma looks like. It is categorized by epithelioid granulomas, Langerhans cell, chronic inflammation, fibrosis, and the case necrosis, the part, it comes in the later stages. So this histological evidence explains the menstrual reduction. 2. support this and to study this, we conducted a prospective observational study for a time period of 1 year at a tertiary care center, including a total of 120 women, which were in the age group of 20 to 40 years. But the main part of the study was that we included two main symptoms, hypomenorrhea as well as infertility. The exclusions are pregnancy or lactation was excluded, use of hormonal or OCPs, endocrine disorders, structural uterine abnormalities, conditions like active PID, CKD, CLD, pelvic malignancy, immunosuppression, which may mimic but cannot help in reaching the main diagnosis. These simple patients and all the patients were evaluated through a simple transvaginal sonography, followed by, in the late luteal phase, by endometrial aspirate or endometrial biopsy. Then that was evaluated by PCR, gene expert, and histopathological evaluation. As you can see the study flow charts, all the 120 patients were subjected to the clear investigations. The striking three results I'll show you, which will make you think once again why hypomenorrhea should be included and taken as an early clinical marker. The first finding, 3/4 of the women who had come to my OPD with the history of hypomenorrhea were screened positive for female genital TB. Now, this shows the clear association between the two. Second feature was that between the positive association between the thin endometrium and the intrauterine adhesions. As you can see, the p-value is less than 0.05. The third striking feature was that of all the diagnostic tests we had used, PCR yielded the most diagnostic results, followed by gene expert and then the histopathological examination. So this results also tells not only pathology or histopathology, molecular diagnostics can outperform histopathology. So considering all the factors and for the clinicians, we devised a novel risk scoring system, a very simple scoring system in which we took 4 markers currently: hypomenorrhea, thin endometrium, adhesions, and infertility more than equal to 2 years. And to that thing, each got a score of 2. Infertility more than 2 years got a score of 1. The interpretation goes here like this: 0 to 2 scored was for low risk, 3 to 5 considered was intermediate risk, and 6 or more than 6 were high suspicion of female genital TB. I tell you, this is the first proposed clinical screening model which has helped us in dealing with the patients and letting them know that yes, they can go to the infertility part and letting them detect at an earlier stage. Now, how we are using this clinical algorithm tomorrow? See, when a patient comes to the OPD part, hypomenorrhea, yes, we do a simple transvaginal sonography where we find thin endometrium. Hypomenorrhea gives 2 score, thin endometrium gets a score of 2. If there is irregular endometrial lining or if we can see endometrial calcifications, then it also goes in favor of intrauterine adhesions, and that gets a score of 2 also. Then if the risk score comes of according to the high suspicion part, 6 or more than 6, they are followed by basic test investigations, which help them reaching to an earlier diagnosis. And what is the result? The result is not achieving that the disease is female genital TB. The result is that we are preserving the fertility of that woman. Now, why I am studying this topic and why I'm emphasizing so much that this is so much useful in day-to-day life? Because it has a very clinical impact. Before, the diagnosis of an infertile couple was made after a basic set of investigations were done. But this part, in my study, when the periods become scanty, at that time only it strikes in the mind that yes, it can be a female genital TB, and we go to all that part screening part. what are the potential benefits of that? Earlier treatment, reduced endometrial damage. This is the most important thing, because once the endometrium is disturbed and distorted, it is very difficult to make it clear again. And finally, better reproductive outcomes are there. So what is the take-home message for my presentation? The three things only you have to remember. First one, scanty periods are not always benign. Hypomenorrhea may be an earliest sign of genital TB, and early suspicion can preserve fertility. I conclude my study by telling you that scanty menstrual flow is a clinical significant early marker of female genital TB, and here it deserves a greater attention during the infertility evaluation. Limitations of my study were that it is a single center study, relatively 120 patients, a relatively small sample size. It was an prospective observational design and lack of long-term follow-up. Two of the contrasting studies I have put to your notice, study done by Chandrakar et al. In 2023 and Sahai et al. In 2023. They both have reported hypomenorrhea only 30 and 27.7% while they were investigating the genital TB patients. Now, what could have been the differentiating part from my study, and why in my study I have got 3/4 of the patients presenting with hypomenorrhea tested positive for female genital TB? The first thing, it can be due to geographical factors and the sample size. But the second most important thing was that they included only the infertile patients and ignored the hypomenorrhea patient. That excluded the main lot. So if they had included the hypomenorrhea part in their study, then their study had shown maybe other results. So these are my references, but this message is a very strong message, and I hope it instills in every doctor's mind why we are sharing this and why we are here today, not just to share our knowledge, but to gain from it and to use in our clinical practices, that not every light period is harmless, and hypomenorrhea may be the uterus's earliest warning sign of genital TB. If we listen earlier, we may diagnose earlier and preserve a woman's fertility. Thank you so much for your attention, and I hope I may not have bored you too much.